Hey, hi, my name's Andrew Mardell. I'm a clinical nurse educator for cardiac specialty clinics at Foothills Medical Center in Calgary. And I have the pleasure of introducing our speaker for the CHRS Allied Health webinar for today. We have Dr. Glen Sumner, who's an assistant professor in medicine at University of Calgary, Libin Cardiovascular Institute of Alberta in Calgary, and he's an electrophysiologist. Our focus today will be on management of resynchronization pacing non-responders and what are the options. And Dr. Sumner will be talking a little bit about understanding the general approach to optimizing response to resynchronization pacing and to understand the specific options to address non-responders. So welcome, Dr. Sumner.
Thank you very much, Andrew. So just to let people know who are listening on the web, in the webinar that we do have a live group here in Calgary at the Foothills Medical Center, and also in addition to people on the web. So please feel free to ask questions, which I will endeavor to answer. We'll try to leave them all to the end, so we'll leave some good time for questions. So as Andrew has mentioned, we are talking today about non-responders to CRT and what are the important factors. I'm also going to address some of the basic and more advanced or invasive ways that we can address resynchronization non-responders. So here are my relevant disclosures related to devices. So just in terms of the outline, I'm first going to define what is a non-responder to CRT, and then we're going to look at basic or non-invasive approaches to these patients, as well as advanced or more invasive approaches. And we'll try to summarize and then take some questions for about 10 or 15 minutes at the end. So just to recap, many of you will know about cardiac resynchronization therapy, or CRT, the concept behind it. Basically, if we just look at this model of the heart, and we can see here the normal conduction system shown here on the left, and then the activation sequence that would occur with normal ventricular activation from the His-Purkinje system in a healthy patient. So with regards to left bundle branch block, which is our prototypical patient population that we offer resynchronization pacing to, you can see here that on the left side of the screen, there is an absence of ventricular activation, or a very marked delay in ventricular activation with the intrinsic conduction. And then on the right, you can see that with the addition of a left ventricular pacing lead as the bright yellow area in the left lateral wall of the ventricle, there and then the right ventricular pacing can be coordinated to achieve resynchronization, essentially trying to restore some normal activation sequence. Of course, it doesn't ever get to normal, but we aim for that principle to improve the mechanical function of the left ventricle. So who are the people that are most likely responsive to CRT? And we have quite a lot of information on this. That one of the largest studies was the Made It CRT study, which was one of the large randomized controlled trials of resynchronization pacing. It looked at a broad population, predominantly with left bundle branch block, and they showed in their study, they looked at the subgroups that were most likely to be either super responders or high responders to CRT. And this helps us today in terms of understanding who is most likely to respond. And you can see here on the left side, it describes gender as very important. So women, for reasons that aren't quite clear, tend to respond better than men. And we have, some of us will remember that non-ischemic cardiomyopathy has a much greater opportunity to respond, perhaps related to scar burden and other factors, but all comers as non-ischemics tend to respond better to resynchronization pacing. People with QRS durations greater than or equal to 150 milliseconds with a left bundle branch block pattern are also much more likely to respond. And people, the other populations were prior hospitalizations for heart failure, and then a baseline left ventricular end diastolic volume, as you see, 125 mLs per meter squared or greater. So you can see that these people had a high percentage within each of these populations of a defined clinical response that is greater than 15% reduction in left ventricular end systolic volume. The other interesting one, which may relate to propensity for atrial dysrhythmias, if you look at the bottom, is baseline left atrial volume, so under 40 mLs per meter squared, which would be considered close to normal for many patients, and that may be a lower propensity for atrial dysrhythmias and hence better resynchronization pacing overall in terms of a higher percentage. So getting back to the definition of non-response to CRT, we usually evaluate patients at 6 months before we make a definitive decision about response or non-response. So those patients who may respond earlier, we take that into consideration, but we don't define them as a non-responder officially until 6 months in general, and that's consistent with most studies that have been done as well. There's a significant variability in the definition of response. It can vary from everything from heart failure hospitalization to death for mortality, but the standard definitions include a change in cardiac volumes, defined as the left ventricular end systolic volume index reduction of less than 15%. So by corollary, more than 15% change or more than 15% improvement, in other words, lower volume, would be consistent with response. The other definition is patient-centered, a symptom definition. So often New York Heart Association functional class or clinical composite score that was developed by Dr. Milton Packer is another one that is used for understanding the more patient-centered or symptom response to resynchronization pacing. And if they don't respond, then we would define that as, well, we would define non-response as less than 1 New York Heart Association functional class change, for example. So it's important to understand that about 30 to 40% of patients with CRT may be initial non-responders. So a substantial portion, now that's all comers. If we refine it to the population that I showed earlier, those who are tending to respond, that may be a higher rate of response and hence less non-response, but that's all comers roughly. So how do we address this issue if we've got to the 6-month mark and the patient has had no appreciable improvement in so-called reverse remodeling or symptoms, despite optimal medical therapy and other optimal pacing? How do we address it? The first thing is to look at the basic interventions that we could perform, those non-invasive ones essentially. And the first one is to optimize the BIV pacing percentage, or in some cases left ventricular only pacing percentage. And the ideal is to have greater than 98%. I'm going to show a slide later on, just a few slides from now, just to indicate how important that is. The other thing is optimization of atrioventricular and interventricular delay. So remember the diagram of the activation sequence. We're trying to achieve within each individual the optimal timing of electrical activation to achieve the mechanical resynchronization. So we can do that most often today. It's done with device algorithms such as the adaptive CRT algorithm from Medtronic, Smart AV from Boston Scientific, QuickOpt from Abbott, and the Sonar system from ELA. So you may recall that, some of you may recall that we can also do this so-called manually with either ECG optimization or echo optimization. I'm not going to discuss that in too much detail today, but essentially with ECG, you're just trying to make the QRS as narrow as possible or to achieve the best base to apex activation sequence. And with echo, we have certain parameters that can be looked at, such as the outflow tract determination of cardiac index or output, and looking at left ventricular filling through the mitral valve as well. I'm not going to talk about that in much detail, but I'll go through a little more detail about the device algorithm. The other thing is, that's very important, is to minimize the atrial dysrhythmia burden, and I've put down what the device commonly annotates, which is ATAF and a flutter burden. So the first advanced or invasive intervention could be lead repositioning, and that would be to just determine an optimal location, usually in the posterior or posterolateral circulation of the coronary sinus. We ideally want to avoid local scar, which can be evaluated by looking at the initial pacing activation locally and other methods such as cardiac MRI. So multipoint pacing has come to the forefront recently using quadrupolar leads. I'm going to discuss that in a little more detail a few slides from now. Also His bundle pacing and left ventricular endocardial pacing, all of which have been relatively recently studied in the last 5 to 7 years, really. So let's look at the optimization of biventricular or LV-only pacing percentage. This was shown to be very important in a study of 36,935 patients in a large registry of resynchronization pacing, published back in 2011. So this very important study showed here, if you look at the top line, those are the patients that are paced greater than 99.6%, and then you can see the drop-off in the Kaplan-Meier survival curve as you get down with a lower percentage of pacing. The worst, of course, shown here is at under 95% pacing. So this slide just emphasizes the importance of biventricular pacing percentage and actual survival. So this is an important study that looked at these large number of patients that emphasized that we need to pay very careful attention to the biventricular pacing percentage and optimizing that. One of the ways we can optimize it is reducing atrial dysrhythmias, optimizing the AV delay, for example, and reducing premature ventricular beats or any other type of arrhythmias that may interfere with biventricular pacing. Probably one of the more common ones that we see in clinic, though, are patients with atrial fibrillation with uncontrolled ventricular response above the lower pacing rate. So optimizing AV delays, I mentioned that you could do it manually with ECG or echo, but you can also do it with an algorithm, and I'm just going to show the results from the, some of the results from the adaptive CRT trial. We had some Canadian involvement there from Dr. Burney in Ottawa, and he published this along with his colleagues back in 2017, and the results were important in the sense that there was a clear improvement with this ACRT algorithm in the burden of atrial fibrillation. It dropped by about 46%, as you can see just with the hazard ratio in the upper left corner there. And that's important probably because we're improving the overall percentage of biventricular pacing and other factors, of course, if you lower atrial fibrillation burden. So what is this algorithm? Well, I haven't shown it here, but essentially what is involved is essentially with a sensed AV delay under 200 milliseconds, so in other words, a relatively normal AV delay, it will pace LV only, and that allows for the heart's own intrinsic activation, a fusion of the left ventricular pace beat and the intrinsic right ventricular activation, which is believed to be beneficial in this way. And we certainly know that high burdens of right ventricular pacing can lead to atrial fibrillation in patients who are not CRT patients. So essentially, and if there's a paced AV delay less than 250 milliseconds, it will similarly do the same. So this would not apply to people with, for example, high-grade AV block or high degree of intrinsic conduction disease where they're not having those parameters for their AV delay. So minimizing atrial fibrillation burden, it may be one of the important ways that that ACRT algorithm works. So the other major way we can do, we can garner an improvement in the atrial fibrillation burden is with antiarrhythmic drugs, predominantly amiodarone. So with heart failure, that's likely the best drug we have right now in terms of its use in maintaining a rhythm control strategy. And to be truthful, we don't know whether a rhythm control or rate control strategy is better, but most of us at the moment, pending other information, will aim for, when feasible, a rhythm control strategy. And when I say when feasible, it's usually based on the baseline left atrial volume. The other way to do it is to do pulmonary vein isolation, and this is a study that was just published in February of this year. Quite a large study called CASTLE AF, and although it doesn't directly address resynchronization patients, synchronization pacing patients, there were some in the study. It does pertain more directly to heart failure, and these patients were randomized to receive either pulmonary vein isolation or usual medical care for their atrial fibrillation, and it showed that an atrial ablation, or sorry, a PVI, or pulmonary vein isolation procedure, was far superior to medical therapy alone for their atrial dysrhythmias in terms of the outcomes, which you can see are death or hospitalization for worsening heart failure. So the hazard ratio was quite significant at 0.62, so a relative reduction of 38% for these events with significant p-values. So very important study, and it's not directly pertinent to CRT, but it does have relevance in the sense that our CRT patients have significant heart failure and a high burden of atrial fibrillation. So I want to spend some more time now discussing the advanced or more invasive approaches to non-responders to CRT. And so we've talked briefly, just mentioned earlier, about the left ventricular lead repositioning, and that's important and was again shown to be very important in a large cohort of patients in MADE-IT CRT, so one of the large randomized controlled trials. And this shows the way that we approach looking at lead position. So on the left panel, you're basically looking at an RAO view, which allows assessment of the base to the apex relationship. And you can see that the diagram is labeled basal, mid, and apical. And then on the right panel, you see the steep LAO projection, which with the coronary sinus imaged on the right-hand side, you can see the branches of the coronary sinus that will correspond to the various territories. And this refers to, mainly we can assess whether it's posterior, posterolateral, posterior, lateral, anterolateral, or frankly anterior. And this is very relevant in terms of our initial approach to lead placement, because the aim is to be as basal as possible, and most likely in many patients as posterolateral as possible. Now that's going to vary significantly based on the degree of scar and other anatomical factors related to the coronary sinus. In other words, the ability to access those areas. But that's a general principle that we want to try to achieve to improve response. So if patients don't have an ideal response and there is feasibility with coronary sinus imaging, for example, coronary sinus CT imaging, that might indicate a more favorable branch, then it's a reasonable thing to consider anyway, to try to reposition the lead. So this is the same study that I was just showing you, essentially shows that whether it's in a posterior, anterior, or lateral position, there wasn't a great deal of difference in terms of the study outcome of heart failure or death, so admission for heart failure or overt mortality with respect to those locations. But if we had comparing apical to non-apical, there was a very significant worsening of survival with an apically placed lead. So again, from a practical purposes in the operating room, we want to make sure that we look in RAO to see how basal we are. So basal and mid is probably okay, and that's the non-apical distinction there. But anything apical, as defined by that RAO view that I showed you, is associated actually with worse outcome and mortality. So it's actually could be potentially harmful in many patients. So let's turn our attention now to multipoint pacing, which is a little bit newer in terms of its overall concept. So I want to talk about the rationale, the techniques, and the results overall. So this slide is just intended to show the difference from the standpoint of what happens with the ventricular activation with pacing with single site pacing. So you can see on the top panel on the left, you have two pacing sites, one in the right ventricle, apex, and one in the lateral wall of the left ventricle. And then on the right panel, with the red area being the earliest activation with pacing, you can see that the idea here on the single pacing site, you're just getting a relatively smaller activation site compared to the bottom panel here, where there's two sites of activation in the left ventricle. You can see that the red portion is much larger. So that's believed to be how multi-site pacing works. So even in the setting of a lot of scar or severe myocardial disease, that type of strategy for pacing is going to activate the most myocardium, the highest volume of myocardium, and that's believed to be how that type of pacing works. So there's an electrical benefit, heterogeneity in location of the conduction block and activation pattern. There's a shorter activation time because of the higher volume of captured heart or myocardium. And there's a mechanical benefit. So in some evaluations, we measured asynchrony, for example, by echo or other modalities, and it's reduced by an estimated 20%. So in other words, we never achieved the perfection of how it was before the left bundle branch block, but much closer to it perhaps with multipoint pacing. There's also a hemodynamic benefit, and that can mitigate the effects I mentioned of the scar by optimizing the volume to improve the hemodynamic response. So it's important to mention that you can do multipoint pacing really in two broad ways, but there's a very recent study just published this fall, in fact, in Heart Rhythm, about looking at two leads, pacing from two different leads within the coronary sinus, and comparing that to the usual pacing. But they found in that trial that the multi-lead approach was actually potentially harmful due to the number of adverse events that occurred, including infection related to the longer procedure. So I'm going to focus on the one that's simpler in a sense, because it's basically using our usual quadrupolar leads that I'll show you in just a moment, and that just pacing from the two sites. So this just shows the array of leads that we now have available from various different companies to provide resynchronization pacing. It's been a huge advance because of the fact that we can optimize our lead position. We can, in fact, make it more stable, but yet potentially pace from a basal location or a better location than we did before. And with respect to multi-point pacing, most of the manufacturers are now developing that algorithm. And in fact, that is very much facilitated by having quadrupolar pacing, or quadrupolar leads, rather. So if we think about how it actually works, this is the initial efficacy study from St. Jude, now Abbott, but essentially looking at multi-point pacing. You can see that what they've done is looked at the optimal spatial separation of the leads on the left side. You still have a significantly good response to CRT with about 63%. But if you look on the right panel, with the lead separation being greater than 30 millimeters and a 5 millisecond delay in terms of activation to avoid refractoriness in the myocardium, potentially that probably delivers the best volume activation of the myocardium, and hence an upwards of 87% responder rate to the resynchronization pacing from the multi-point quadrupolar lead. So there was 93% freedom from lead procedure complications. So essentially, this procedure is essentially the same as what we would do. The only proviso is that you have to have the ability to capture from two separate cathodes. If you don't have that, you can't really do the multi-point pacing. So that's the difficult part, is you may have to move the lead some more to find a site where there's two potential cathodes that have a low enough threshold to pace, which is one of the pitfalls of this quadrupolar method. So this is just another study that showed basically a 12-month response rate. Essentially what you're seeing here is that the non-responder rate was reduced from something like 43% down to 24% with multi-point pacing, and correspondingly, of course, the higher overall absolute response rate, upwards of 76% in this particular evaluation, which was at 1 year. Next up is His bundle pacing. Again, that's relatively new, although people have been trying to do this for quite some time. And the concept goes back to what we were chatting about earlier, which is the fact that we're aiming to activate the conduction system, the intrinsic conduction system, just like it would be if there was no disease. So essentially, this slide illustrates that. If you look at the X-ray on the left, you can see two leads that are pointing up. One is the defibrillator lead, and then you have a pace sense right ventricular lead that's going right up to the His bundle labeled HB, and then the atrial lead up there. So essentially, you put in a separate pacing lead to achieve His bundle activation. And then this slide on the right, if you just look at the two panels, up there is the baseline QRS duration of 172 milliseconds. And then when you pace in the His, if you are able to achieve His bundle capture, you can see that the QRS duration goes from 172 to 125, which is very impressive from an electrical standpoint. That may or may not predict response, but it's certainly an impressive improvement in the ventricular activation sequence from the electrocardiogram standpoint. So again, this slide just illustrates what happens. So you've got on the left panel in A, you've got in the middle of the panel, if you just look at that, I'll circle that, that's basically the left bundle, that's the intrinsic rhythm for the patient. Then when you pace and you're successful to get the His bundle, you see a very much narrower QRS complex, labeled around 95 milliseconds there. And then you've got on the right, if you drop the energy for pacing down from 2 volts, you lose capture of the actual His, and you get still capture, but that's not going to be very effective. It's more through the myocardium, so it's still very wide and hence not very useful in terms of resynchronization pacing. But the main message here from His bundle pacing is that if we are successful in getting to the His and is successful in pacing it, then the QRS complex will almost always be significantly narrower. And that's what I'm going to show you here. This was a study that, again, was published just this year, and it's looking at permanent His bundle pacing as a multi-center registry of patients that have undergone this. Now, the population may have been upfront with just AV block, or they may have been done with non-responders. So it's a broad population. It's not just non-responders to resynchronization pacing, but it's extremely impressive what they show in this registry. And it's worth spending a little bit of time on this, because if you just look at the left panel, again, the QRS duration. So essentially, the baseline QRS duration is in blue or purple, and the His bundle pacing is in red. And you can see going from left to right, you can see that there's an incredibly impressive drop in the QRS duration. Like, for example, overall dropping from 157 on average down to 118. So essentially, it would be normal, or the upper limits in normal, but normal still. And if you look at people with bundle branch block, they have a little higher average baseline QRS duration, and they drop down to 116. Again, the ventricular pace, you don't get as impressive a drop, but it's still pretty good. So it starts off at a higher value of 177, you end up at 125 on average. All of these are very significant. They also tried pacing in normal QRSs, and there wasn't a great deal of difference. But if you just put it in your mind that if you put a right ventricular pacing lead at the right ventricular apex, and you start pacing that patient, that is going to be a very wide QRS. So the fact that they were able to achieve, even with the normal QRS in patients with heart block, essentially either remaining the same or relatively the same, it's very impressive. So on the middle panel, that's even more good news there with respect to this registry. So select patients, we have to be careful, it's not a randomized trial, but it is still very impressive preliminary data about his bundle pacing. So left ventricular systolic function overall improves from 30 to 44%. People with very severe left ventricular systolic function improve even more in absolute terms, perhaps, or close to it, just more, from 25 to 40%. And then with your baseline ejection fraction, which is often our patient population that just have heart block, for example, and may have some mild unexplained left ventricular systolic dysfunction, if you do his bundle pacing, you're going to actually improve their ejection fraction. The NYHA functional class is equally favorable. As you can see, the purple numbers, the baseline higher New York Heart Association functional class, as we know, is worse. And so you can see that there's improvement or drop in the average NYHA functional class or clinical competence score. I think they also have that in the registry. I didn't show that, but this is an impressive drop in symptoms. So both the patient-centered and the reverse remodeling with his bundle pacing in a registry, not a randomized trial, but still very, very good. So endocardial CRT is another relatively new arrival. It's been done for some time, but only recently have there been published clinical trials. I'm going to show you that as well as a meta-analysis. So talk about that briefly. So the principle here with endocardial pacing. So endocardial, of course, we're coming from the inside of the left ventricle as opposed to the other leads that we were talking about, which are on the surface of the ventricle. So with regards to endocardial left ventricular pacing, the main message here is that the velocity of activation is much higher. It's very subtle in this picture, but if you just focus on the bottom two, you can see that there is less late activation on the fast endocardial conduction. This is actually a mathematical model in canines, but it does apply to show the principles of endocardial pacing, which is essentially that the activation sequence will be improved to an even greater extent than potentially than epicardial pacing. So it's a little more complicated to do, though, in terms of getting to the left ventricular endocardium. You have to go either trans-septal in the atrium, and other investigators have done trans-septal in the ventricle, but most go through the atrium, and you can see this X-ray diagram right at the right atrial lead just on the left-hand side there, and that catheter that's pointing 6227 ATS is the catheter that's going to go across the septum with a wire going into the left side of the heart. And you can see that they've used echo to guide them. ICE is commonly used for this procedure to see that you're not going to injure the aorta, which is right there, essentially, as it is with all trans-septal. So you're coming basically from the top like you normally would with an implant, and you're using this special guide that's proprietary catheter to deliver a wire to the across into the left atrium and then into the left ventricle, and then putting the guide in further and delivering the lead like this. So you can see on the left side, you basically have that lead that's with that curve on the lateral aspect of the ventricle. That's the actual deployed left ventricular lead inside the left ventricle. So the issue with endocardial CRT, I'm going to show you. First of all, the positive news is that a meta-analysis looked at from dating from even 1999 all the way out to the largest study, which is called ALSYNC, that was published in 2016 with a fair amount of Canadian involvement from our colleagues in the EP community. And it shows that the summation of the meta-analysis was that there was a very substantive response clinically to resynchronization pacing with an endocardial left ventricular lead. That is shown at the bottom of the screen, where you look at the estimate for all studies, and it's that diamond-shaped red structure. So very impressive in terms of the overall response rate related in likelihood to the activation there. So the problem with endocardial CRT is that there is well, at the moment, a significantly higher risk of a stroke and TIA. Now, that's being refined because anticoagulation regimens initially were just targeting like we do for atrial fibrillation. But whenever you have a lead on the left side of the heart, that can be problematic. And that was the issue, believed to be the issue here. So you see, if we look at event rates per 100 patient years, so if you had 100 patients followed for a year, you're going to have 2.5 of them are going to have a stroke, which is pretty high. The TIA 2.6%, combined stroke or TIA 6% or so, and death of 4.5%. Now, granted, these patients are very higher risk, so they may be non-responders to CRT. They have complex cardiac disease, so they're not, even though we have generally high-risk patients are receiving CRT, these are even potentially higher risk, so we have to keep that in mind when we're looking at this data. But it does give us pause when we have to tell somebody that the potential stroke risk is that high. However, the efficacy is very good. So people achieving New York Heart Association functional class 1 or 0 basically was about 60%. Reverse remodeling 55% by our standard definition of greater than 15% reduction in the end systolic volume index. The super responders, as they defined by greater than 30% reduction in systolic volume, was fully 1/3 of the patients, which is very impressive. And these are people who were initially not responders to CRT in many cases. And a left ventricular ejection fraction greater than or equal to 5% was also impressive, nearly 2/3. So the efficacy is very good, likely related to the fact of how things are how the electrical activation sequence is achieved with endocardial pacing. But the risk of stroke, of course, is a challenge. So this is a total mortality from this big study, the ALSYNC study. Bleeding stroke risk went down a little bit, but then the overall stroke rate was quite high. Some patients with subtherapeutic INRs, and that was attributed to that and having clot on their left ventricular endocardial lead. There was a relatively similar rate of dislodgement at 4.5%, implant failure rate higher than standard CRT, of course, and a very small aortic injury risk, but that's something that obviously needs to be avoided. So if we just look at all the types of pacing, this slide just illustrates that. So the MSP 1 and 2 are just multi-site pacing with either a lead, 2 leads, or 1 lead, and they're essentially giving you a percent change in hemodynamic response that's quite impressive, of up to 15%. The best one is if you can find the best site and test it in the lab or in the OR, the best endocardial BIV pacing seems to win out in terms of the acute hemodynamic response. Now, keep in mind, this does not necessarily predict like longer-term clinical response, but it does show it illustrates that the biventricular endocardial pacing, at least in this metric, seems to perform very well and better than the standard conventional CRT, for example. So in summary, in order to address the CRT non-responders, there's a few strategies. The best strategy, of course, is prevention, so selection and optimal medical therapy and maintaining the optimal medical therapy with the CRT. We usually wait until 6 months before we determine the response or non-response definitively. We try non-invasive methods first before re-intervention. And in the immediate future, it seems that both multipoint pacing from the quadrupolar lead or his-bundle pacing is our likely safest advanced approaches, are our likely safest advanced approaches right now. And further clinical trials on his-bundle pacing are currently pending. So we'll take some questions. So with the local folks, I'm happy to wait around and just answer questions. We'll just see if there's any people that are questions here online. No open questions at the moment. So perhaps we can take some questions from here if anyone does have questions. I'm glad to do that. Glad to take them.
I have a question.
Sure.
Can you comment on the role of some of the automated programming like MPP around the efficacy of being able to do in-clinic programming to some of these patients that might require finessing in the timing of their LV timing and AV timing?
Sure. So the question is about the optimal settings, I believe, for, you're asking about the optimal settings for MPP and in the clinic, trying to figure out the best timing. So based on the limited data that we have from the MPP trial, which was Abbott-based, that would suggest that the spacing of 30 millimeters, that's already determined, but the sort of greater than 5 milliseconds or thereabouts, 5 milliseconds or greater timing would be the best. So that's about all the information that I have. You could, in terms of trying to optimize it by ECG data, I don't have any experience with that, to be quite honest with you. But there's certainly from the registry data for MPP, those were those three settings that they showed, sort of the extremes, but those were the best ones. In theory, you could look at a manual optimization with the activation sequence being the best electrically, or an echo optimization, but there really hasn't been any studies, to my knowledge, that have shown that to be beneficial. Some of the MPP studies, of course, that I showed, the ones I showed last, just look at acute hemodynamic response, but again, that's not necessarily always going to translate into a better clinical outcome. So with respect, and program it up front at the moment. So it's only indicated if people are non-responders. So with issues related to battery life and also potential arrhythmogenesis, things that we don't yet fully understand. So at the moment, its role is still in people who are defined to be non-responders before we would turn on the MPP. Anything else? Any other questions? All right then. Thank you.